Well, good afternoon, everyone. I'm Mike Bromersky, the superintendent of the Hempfield School District. We're pleased to bring you a presentation today from Dr. Martin, who's with Penn Medicine Lancaster General Health. I just want to start off by saying we're extremely proud of our partnership with Penn Medicine Lancaster General Health and so appreciative of all the work that they've done to help schools in the county reopen in a safe way. I'm also thankful to our county commissioners who supported and allocated federal funds for this partnership. So thank you to everybody who's been working extremely hard to help our students stay in school, whether it's in person or virtual. And for today, Dr. Martin, who's the medical director of Lancaster County's contact tracing program and the chair of the Department of Family and Community Medicine at Penn Medicine Lancaster General Health, will be talking about COVID-19 in schools as well as COVID-19 in the community. So just giving an update about where we are, what's working, what are some of our current challenges, and also at the end, all of our attendees will have the opportunity to ask questions. So if you have questions throughout Dr. Martin's presentation, please put your question in the chat box. We'll be monitoring the chat box, and at the end, we'll go through those questions. As long as we have the time to commit based on our schedule today, we'll certainly go through all those. And if we can't get to all the questions, we'll work to get those questions answered and out to all the school districts. We're also recording this session, so if someone is not able to attend, we will be sending the link to this session to all the school districts, public and non-public, here in Lancaster County. So with that, Dr. Martin, I'll turn it over to you.
Thank you very much, Mike. And I have to echo that we're very excited and proud to be part of the school partnership that we have engaged in here over the past couple months. I think we've done good work together with the county's blessing, and hopefully we continue to engage well over the next few months. So this is actually the first in a series of 2 webinars, as Mike said. And basically for this webinar, I wanted to just lay out the current state, give some reminders about what contact tracing, isolation, and quarantine are, and talk a little bit about where we're at currently in Lancaster County around testing. And the next webinar is going to be about looking into the future a little bit to try to forecast what might be happening as we enter the winter months with COVID and some of the opportunities and challenges that we have to face that. So for today, we'll go over the current state. We'll talk about what our current social distancing and mitigation measures are in the county. I'll give an update on contact tracing, give you some definitions around isolation and quarantine, and talk about testing. But really, I think the 3 main goals for this talk are to let you all know where we are at with COVID in our community and schools right now, what we are doing about it, and how can our schools and community work together around shared outcomes. And again, the next webinar, Thursday this week at noon, will be looking a little bit more into what the future might hold with relationship to COVID in schools. So currently, this is just a summary slide of what happened over the past week. And we continue to see a pretty high incidence rate of new COVID cases. In fact, it's the highest since we've seen since springtime when we had our first surge. Over the past week, there are 386 new cases in Lancaster County. Our incidence rate increased slightly from 70.1 to 71. Now remember that the Department of Health has said if we get to 100 cases per 100,000, that puts us into the high community spread category. We're in the moderate community spread right now. We've had increasing hospitalizations and deaths as a result of these increasing cases. So it's not just an increase in cases, where we're seeing the downstream effects of those in the hospital. As of Monday, LG Health has 23 COVID-19 inpatients, including 9 in the ICU and 2 on ventilators. There were 4 additional deaths reported past week. Along with the increasing incidence of cases, the percentage of positive tests have also increased from 3.2% to 4.7%. Again, we want to try to keep that under 5% because it's a marker of how well we're testing in the county and also how much COVID is in the community. The turnaround times for our community testing has increased slightly from 2.2 days to 2.5 days. And the contact tracing program is going well. I'll go over all that as we go through the slides here. So let's talk about COVID-19 cases, hospitalizations, and deaths. And I'd like to start with a current map of where COVID is now surging across the US. As you may recall, during the first surge, we saw pockets in the Northeast, specifically around New York and Connecticut. The second surge that we had around the middle of June into July and August was primarily in the southern states. So you saw a lot of red across the southern part of the US. And this, being the third surge, appears to be pretty broadly based across the entire country. So you see the upper Midwest, the Midwest, and even some hotspots in the Mid-Atlantic region where we're at. But if you look out west at some of the lower population states like North Dakota, South Dakota, Montana, Idaho, Wyoming, you see an awful lot of red around there. Utah, really the only part of the country at this point where COVID does not seem to be surging is primarily in the far northwest, so Washington, Oregon, and California, but we're starting to see some pickup around the big population centers there as well. So this is a somewhat of a unique surge in the fact that it's pretty widespread. It's not particular to really any part in the country. And I think the incidence cases that we're seeing here in Lancaster County are reflective of that. The next slide, I want to just kind of give you an animation of what's been happening with the United States in comparison to other countries in the world. I think sometimes we hear a lot about where we're at and how we're doing, but we really don't have a sense of what's happened over time. So the next slide is an animation, and it gives you an idea from the start of the pandemic to current state, where the United States has been in relationship to other countries around the world. I limited it to countries that have 100 million population or more. It is cases per 100,000, so it is comparing apples to apples. It's not cumulative cases or just total number of cases. It's only looking at the number of cases per 100,000. So each rate that you'll see on that graph, it will be reflective of the incidence rate of each county that's shown. I'm sorry, country that's shown. So you can see the United States started out fairly high early on in the pandemic. We started to come down. You saw Brazil go up. And then the second surge around June, July hit. And we came down not quite to where we were at the baseline. And then really over the past month or so, you're starting to see a pretty big increase in cases in the United States. So maybe I'll go through that again. So you see the first initial big surge. We dropped down. That was when the stay-at-home orders came into place. Then you saw the second big surge. This was after people, I think, were kind of getting tired of stay at home and we started to open up a little bit. And then there was a pushback again. Mitigation measures were put into place. And now we're in the midst of a third surge. We're not quite up where the European Union is at this point. They're definitely struggling currently. So what's happening in Lancaster County? So this is just taking a look at Lancaster County, which is the orange line in relationship to all the other counties in Pennsylvania. And then the blue line is the average for Pennsylvania. And for the first time in a while, we've actually dropped below the average of the PA curve. We were quite a bit higher than it in June and even early July. We came down to it, we went up again. And then we've been kind of tracking along with it, but we haven't remained flat. If you look back in the September 28th to where we are now, you see this steady, slow increase in cases that have occurred. But again, we have stayed below, at least over the past week, maybe week and a half, below the average of the Pennsylvania curve. This big line that's coming in from the left-hand top of the graph is Center County. That's due to cases at Penn State. And some of these outlier counties like Huntington, Bradford, Lebanon, and other places are due in part to some outbreaks in nursing homes and some outbreaks in prisons. So if you look overall where we're actually down the list quite a bit than where we've been. We were the highest incident rate county in the state on June 29th. We're certainly nowhere near the highest at this point and actually below the PA average. So this is a graph that just looks at the percentage of positive tests over the past 7 days. And as I mentioned, we had a slight increase from 3.9% to 4.7%. We're trying to keep this under 5%, which is really the target. There's definitely been a steady increase since, again, the end of September in the number of positive tests that we have. We feel like this is reflective of the fact that we are now testing asymptomatic contacts, which will have a higher chance of having COVID than people who are not exposed to somebody with COVID who gets tested. So I think that's reflective of us increasing the number of tests for those asymptomatic contacts. This is just another graph that takes a look at surrounding counties next to us, and again shows you the first curve that happened at the beginning of the pandemic, the second curve that started in mid-July and into August, and now the third surge that we're seeing here in October and heading into November. And again, I'm going to give you one other chance. I hope these animation slides don't make you dizzy, but this is going to compare Pennsylvania to the other states in the Mid-Atlantic and the Northeast region, because I think it's interesting to see where Pennsylvania stands with regards to New York, New Jersey, Massachusetts, Connecticut over the length of the pandemic. So again, New York got hit pretty hard, as did New Jersey. Pennsylvania did not do quite as bad during the first surge. However, over the second surge, towards the end of July, mid-August, we were probably the worst in the Northeast. And now you can see towards the end here that a lot of states in our region are doing poorly. So again, I think this is reflective of the fact that the incidents and cases are happening in beyond just a regional level now and are really affecting many states throughout the US in total. So I'll let this finish running and then I'll click on to the next slide. So it's not enough to just look at cases. Cases are one measure of what's happening. But if you start to see cases end up as deaths and as hospitalizations, you have an understanding that it's not just that we're identifying more cases, it's that we actually are having more significant community spread. So this is just a graph looking at what our current census has been or is as of yesterday, where we have 23 patients, as I mentioned, 9 in the ICU, 2 on ventilators. This is actually the highest number of hospitalizations that we've had really since that second surge that we had towards the end of August as it started to wane. We are still well within the capacity of the hospital. However, there is a higher census, and typically our hospital has a higher census as we enter the winter months because of influenza and the winter viruses that tend to drive hospitalizations. So we want to keep a very close eye on this, and obviously there's concern that if cases continue to trend upward, that we're going to have to be creative and certainly find ways in which to care for those folks appropriately. We do have plenty of available ventilators. We would have to institute some surge planning in order to have some more ICU beds. But this is not unique to Lancaster General. This is actually happening across the state of Pennsylvania as a whole. As I mentioned, 2 deaths have had a slow and steady increase from mid-September. We are certainly thankful that we're not seeing the amount of deaths that we saw early on in the pandemic in April and May. But in mid-September, late September, we had times when we didn't have any deaths, and that was very nice. We obviously don't want to see that, but we are seeing a slight uptick in the number of people dying of the COVID virus. All right, so let's talk a little bit about where Lancaster County is with regards to its risk behaviors. So I identify risk behaviors as how are we doing around social distancing? How are we doing around non-essential travel to businesses that would be deemed non-essential? How are we doing with regards to mask wearing, et cetera? So the exposure definition, meaning how do you determine if someone is a contact to someone who has COVID, continues to be within 6 feet for more than 15 minutes. But Department of Health has had some caveats. So two people that are standing next to each other that are unmasked and happen to be coughing or sneezing on each other, even if it's not more than 15 minutes, may be a high risk exposure and probably is. So there's nothing magical necessarily about 6 feet and 15 minutes. There are still the potential for droplets to spread beyond 6 feet. But in order to operationalize this with schools, we need to have come up with a definition related to 6 feet and the 15 minutes. There's been some talk about whether this is a consecutive versus a cumulative, and I think Department of Health, at least in Pennsylvania, is basically saying, yes, 6 feet within 15 minutes on a consecutive basis is the correct definition because that's really the only one you can operationalize, but there may be some caveats. So if a teacher is walking around a room and has a lot of very many exposures for a longer period of time, that might be considered a contact as well. If two football players are playing on the football field, they may not be within 6 feet for more than 15 minutes, but when they are, they're face to face and breathing heavy and grunting in each other's faces. That may be considered a high risk exposure. So they've really taken the stance that 6 feet within 15 minutes is how we're going to operationalize this, but with the caveat that sometimes there may be other high risk exposures that they would deem as being meeting the definition. And I know this has been somewhat difficult for schools to think about, and especially as we open up and have more in-school education, that's going to continue to be a challenge. So how's our community doing? So there are several places, including the Children's Hospital of Philadelphia and the CDC, that take a look at publicly available cell phone data to determine how well people are doing in terms of travel to non-essential businesses, to parks and recreation, to workplaces, et cetera. And they model it every week. And what has consistently been the pattern in Lancaster County is that we have had really fairly poor social distancing metrics as compared to surrounding counties. So what they do is they look at the percent below the baseline, which was prior to having the COVID virus in the county and prior to any stay-at-home orders. And what you consistently see is that Lancaster County, compared to other counties next to us that touch us, our social distancing rates continue to be closer to baseline than other counties. So in other words, we're doing worse in terms of our social distancing compared to Berks, Chester, Dauphin, Lebanon, and York County. And I don't know why. I've tried to think about, is there something inherent in Lancaster County that makes us not want to follow the guidance related to travel to non-essential businesses and so forth, but I'm not exactly sure why that is. The various models can then model the projected cases based on the social distancing practices. And as you see, this little dotted line at the end of this graph is what's projected in terms of cases due to the social distancing rates that we have. I'd just like to say one more thing about social distancing and especially travel or going to high risk activities. It's not really about where you go. That's how it was early on. If you traveled to certain states or certain countries, there was risk, but it's not uh, like that now, since the risk is sort of spread throughout the entire U.S. And pretty much in many communities, large and small. So it's not really where you go in terms of travel, but it's really what you do when you get there. And this is really a nice slide. I think I did show this on one of my first webinars that kind of breaks down activities into low, medium, and high risk activities. We now have some good data, including a paper that was recently published that took a look at people within the same clinic, people that had symptoms and did not have COVID, and people with symptoms that did had COVID. And they looked at the contacts for each of those groups, and they used the folks that had symptoms that did not have COVID as the control group. And what they found was that, and this was done in July, so think about, how open folks were. I think this was done in the Northwest, how open communities were in July. But at least in July, it showed that there was a significant difference between people without COVID and those with COVID who had visited restaurants. And they didn't differentiate between being indoor in the restaurant, being on a patio, or being in an outdoor setting at the restaurant. They also found a significant difference for people that had visited bars or coffee shops. There were a couple other areas in the community that looked to be high risk, but that were not statistically significant, and that included gyms and religious gatherings. It was interesting to find out that shopping, grocery shopping, being at home, both in large families and small families, going to work, going to salons, using public transportation, were all shown to be lower risk activities. So I think this really puts some science behind what we've been saying for a while now, that there are higher risk activities that can occur in the community that might expose you to COVID or put somebody else at risk for COVID if you have it. And certainly I think restaurants, bars and coffee shops, gyms, and religious gatherings continue to be fairly high on that list. Now remember, this was done in July. I believe they're going to repeat this study because it'd be interesting to see, since in July there were not many bars, restaurants, religious gatherings open, and as we increase access to those places, what will happen in terms of the risk related to contacts in those locations. I still think that it's this graphic is very nice to kind of give everybody an idea about, what are those high risk activities, what are the low risk activities, what should you be doing when cases rise in your community. We also have some good data now around what the effect of stay-at-home orders were. And this was a study that looked at the doubling time for the COVID virus. So as you can see on the left side of the graph, that the doubling time, meaning the time somebody who had COVID ended up passing it on to somebody else, was generally around 5 to 10 days for all the states. But when they instituted stay-at-home orders, that doubling time went up dramatically. What that means is that the spread was not as quick as it happened. And I think that's what you saw in the animation graphs that I showed you initially. There was quite a bit higher spread in that first surge, steeper curves, came down steep as well. But we saw sort of less of that and a more gradual curve during the second surge. This third surge, I think, for the most part, is probably going to be similar in respects to the second surge, in that we're not going to be seeing very steep curves necessarily, except in certain identified communities. But at this point, nobody really seems to have the stomach to institute more stay-at-home orders. But I just want to show you that they did work. They did reduce the spread of the virus, and that was some important, I think, epidemiologic information that we got here recently. Let me talk again about masks. Again, since I last spoke to you, there's been a lot more literature around masks. They do work. They do reduce airborne transmission of the virus. And most folks would recognize or say that masks also protect the wearer as well. We used to say that my mask protects you, your mask protects me. But in reality, I think the mask protects other people as well as yourself. There's a really nice YouTube video. I'm not going to show it. You kind of have to have the stomach for it. But I think it would be something great to show, especially to kids in a classroom, the difference between droplets that are expelled when you don't have a mask on versus when you have a cloth mask, a surgical mask, or an N95. It's a nice visual representation of how masks actually do prevent the spread of the virus. So there are a lot of mask myths that have developed over the time since we last spoke, and I'd like to address some of these. The first myth is that masks should only be worn when you feel sick. So 40% of COVID transmission happens before someone with the disease even has symptoms. So by the time you put a mask on, if you're feeling sick, you still have potentially spread that virus, and we're seeing a lot of asymptomatic spread that's driving the cases in the community. So you need to wear the mask as much as possible at all times, and not just when you feel sick. Wearing a cloth mask does not protect you from the virus. A 2-ply cloth mask has been shown to be quite good. It's obviously not as good as an N95 or a K95, but it dramatically decreases the risk of shedding droplets, which we know carry the COVID virus. And so cloth masks are definitely helpful. And there's a lot of better sort of information and efficacy around the use of cloth masks. The third myth, wearing a mask will increase the amount of carbon dioxide you breathe and make you sick. This has been completely and utterly debunked. There is no risk to the wearer of the mask for increasing carbon dioxide. Carbon dioxide is a molecule. It's very tiny. It is not stopped from any type of mask, even an N95. It freely goes between your mouth and through the mask and into the air without any impedance. So that is a myth that I've been seeing more and more on social media. If I'm wearing a mask, I don't have to practice social distancing. So this is also not correct. The exposure definition is there regardless of whether you have a mask on or not. So we think that wearing a mask along with social distancing is the most effective way to prevent COVID from spreading from one person to another. So even if you are socially distanced, you should be wearing a mask, especially if you're in a school setting. And certainly if you are more than 6 feet from someone, that is not necessarily the time, especially if you're indoors, to take off your mask. So the fifth myth, mask with exhalation valves. I've been seeing a lot of these around every time I go to the grocery store. And I think people like them because they feel like they can breathe through them. Well, that's the problem. When you have an exhalation valve, the droplets freely go out that exhalation valve. So clearly these masks that have an external valve on it do not offer the same protection. They're probably not much better than not having a mask at all. I don't have to wear a mask outside. If you look at that chart of low risk activities, if you're by yourself and you're walking your dog and you are well aware from groups of people, yes, you don't have to wear your mask. If you are outside for a gathering because your family decided they wanted to get together, but they wanted to do it outside, and there is not an opportunity for strict social distancing, you probably should still wear your mask. We still see COVID spread from person to person outside, outside parties, outside events. And I would strongly encourage everybody not to say, well, we're outside, you don't need a mask. There are instances, certainly, if you're by yourself, you're in your backyard, you don't necessarily have to have your mask on, or if you're going on a jog or riding a bike. All masks are created equally. That is not the case. We have very good evidence around surgical masks, N95s, and cloth masks, but we're still a little bit worried about gaiter mask, bandanas, and certainly the valve type mask. There is evidence that droplets can freely go through those types of masks, and they may be giving wearers a false sense of security. I'll also add that face shields alone do not have a lot of studies behind them, so we're still trying to figure out exactly what someone wearing a face shield, what their risk of spreading droplets is. If you wear a face shield, again, with a mask, that's probably helpful because it prevents the wearer of the face shield from touching their eyes, which can be an entry point for COVID. And then the final myth is that masks can weaken your immune system. I've been seeing a lot of this on social media, even some YouTube videos. Again, there's absolutely no evidence that wearing a mask will weaken your immune system in any way. So what's happening with testing? So right now, because we are having a little more testing and because we're testing asymptomatic contacts, we have seen the turnaround times inch up a little bit. We continue to look at ways in which to keep the capacity up so that we can have quick turnaround times. It's really important for contact tracing for someone who gets tested to get that test result within 2 days. And our target is to try to maintain a 48-hour turnaround time. And I think this is probably going to get better over time as we find new sources to increase our testing capacity. So as a reminder, who should get tested? Anyone with symptoms suggestive of COVID. You should call your doctor and talk to them. If they will assess you, if they feel like the symptoms are suggestive of COVID, they will recommend testing. It's also important to call your doctor because you may have symptoms that look like COVID but are clearly not COVID. So there are a few instances where a provider can rule out COVID based on your symptoms and your exam. Anyone who's been identified as a contact to someone with COVID, even if you are asymptomatic, you should get a test. This is not for a clinical function. It's not to determine whether or not that person is going to get sick or not, but it's really for the public health function of contact tracing. So we know that there's a fair number of those asymptomatic contacts which will have COVID and be unwittingly spreading it. So if we can identify those folks, have them quarantine and isolate as appropriate, that will help decrease the spread in the community. Anyone with symptoms who does not want to get tested, and I've been hearing more and more about this over the past several months, that some people say, well, I have symptoms, but I don't want to get tested. They're concerned about something related to testing, and I'm not exactly sure what that is. But if they don't want to get tested, they will need to isolate as if they have COVID for 10 days. I think it's important to remember that most persons who are referred for testing only have about a 5 to 8% chance of having COVID. So for folks that think they might be doing their family a favor, you're probably doing more of a disservice to your family if you have symptoms and you refuse to get COVID testing, because not only will you need to isolate for 10 days, in some circumstances, the rest of the family will have to quarantine. Yeah, so if you get a test and it's negative, then you won't necessarily have to isolate for 10 days and your family may not need to quarantine. So I think that the recommendation we're currently pushing is that anyone with symptoms really should get a test and not just isolate at home for 10 days. If you are an asymptomatic contact, so I was exposed to somebody who had COVID, I don't have symptoms, I go and get a test, which we're now recommending, and it tests negative, I still need to finish my 14-day quarantine. So having a negative test in that situation does not get you out of quarantine. And the reason for that I'll talk about, but it has to do with essentially the incubation period of the virus. And I'd like to also say that the current tests we have are quite accurate. So there are some false negatives that come up, there are some false positives that come up, but overall they're quite accurate and quite a bit more accurate actually than some of the new antigen tests that are starting to come into our community. So what is contact tracing? I just wanted to remind everybody that the reason we do contact tracing is a way to try to break the chain of infection. This has been used for really over a century or more with any number of pandemics. It's currently used with tracking people for STDs, and it is something that has been shown to be beneficial. Without contact tracing, many more persons will come in contact with the virus. So the way it works is that all cases, so people that have a COVID test and it's positive, they're called and they are asked for any of their contacts during their infectious period. And again, remember, you can be infectious and asymptomatic. And usually that's about 48 hours prior to having any symptoms. So those cases are called. They're asked about their contacts 48 hours prior to having symptoms and up until the time they're in isolation. And then the contacts of that case are called. The contacts do not know who the case is. Sometimes if it's a household member, obviously they would know. But a lot of times if it's a community contact or an in-school contact, we try to maintain the privacy between those who have COVID and those who are contacts. All household members are really considered contacts. And the reason for that is that it's almost impossible to isolate effectively at home, to not share the same bathroom, to not share the same eating space. And so essentially the Department of Health has told us that it's unless you have a separate apartment where you can be totally self-sufficient and closed off from other household members, that all household members are considered contacts. So contact tracing slows down the spread of the virus. If you look at the graphic at the right and you have one person with COVID, they can infect two people, those people infect two people, and so on and so on. And 4 generations of the virus, which can happen fairly quickly, you have 16 cases of COVID. But if you contact trace, you break that chain of transmission. So by being able to reach out to contacts that would go on to be potential cases, you prevent them from spreading the virus down this chain. And so instead of having 16 people at the end, you maybe only have 8 or 4. And so it's a way to continue to knock down the spread and incidence of cases in the community. So that's just kind of a basic graphic of how contact tracing works. And let me go over some definitions. So isolation. Isolation is used for someone who has a positive test for the virus. And typically, when people have a positive test after having symptoms, or if they just have a positive test and they're asymptomatic, they need to isolate for 10 days from when they started having symptoms or for when they had the positive test. The minimum is 10 days, and as long as their symptoms have been resolving over 24 hours, they can come out of isolation after that 10-day period. Their contacts need to quarantine. So isolation is used for cases and quarantine is used for contacts. So quarantine is used for someone who's been exposed to the virus, again, within that 6 feet for more than 15-minute definition, or someone who's living in the same household as the case. Because again, it's really difficult for people in the same household to stay separated from each other. So Department of Health has said that all household members should be considered contacts.
Dr. Martin,
Difference, yeah,
really
go
good.
ahead.
Someone posted a question, why 10-day isolation versus a 14-day quarantine since you're in that area right now?
Yeah, I'm gonna get to that.
Perfect.
So so quarantine is used for contacts, people that have been exposed to the virus. And because household members can't isolate effectively from each other, the quarantine for a household member starts 14 days after the initial household case comes out of isolation. That's sometimes confusing for people. A probable case is someone who has COVID and has been exposed to someone with COVID in the last 14 days. Because the incidence rate in these contacts are so high, the public health folks consider them cases. So their contacts need to be quarantined pending the result of the COVID test. If the test is negative, then those people that were quarantined can come out of a quarantine. However, if their test is positive, their contacts need to stay in quarantine. And again, regardless of a negative test, a probable case or someone who's a contact needs to finish their quarantine because they were a contact initially, even if they have a negative test. So the difference between the isolation and quarantine periods are based on the incubation period of the virus. So the incubation period is the time from when someone is exposed to when they might develop symptoms. This usually occurs within 2 to 14 days. The average is around day 6 or 7, but there have been cases of people that can still spread the virus up to 14 days. And so that's where you get the quarantine from. So 14 days from the last exposure, if you quarantine for 14 days, you're going to be pretty sure if you don't have symptoms that you're not going to get COVID from that exposure 14 days prior. So that's related to the incubation period of the virus. The infectious period, however, is the length of time that the average person can spread the virus if they have it. So these are cases. So usually someone who is infected with COVID can spread the virus 48 hours prior to having symptoms and up to 10 days after. So that's why the isolation time is only 10 days. After 10 days, most people are no longer shedding the virus, and they are no longer a risk to being in contact with others. And so that's why the quarantine time is 14 days and the isolation time is only 10 days. I know it doesn't make a lot of sense, and folks sometimes question those lengths of time, but they are based on the inherent scientific information we know about how the virus reacts within the human body and how it spreads. So what does quarantine and isolation mean? I think there's a lot of confusion around this. It basically means you're staying at home except to seek medical care. That means that you don't go to school, you don't go to work, you don't use those 14 days to have folks over who are not in quarantine or other family members that are outside your household. It also means that you don't go to the grocery store, you don't go to soccer practice or band or really any other activity with others except what happens in the home with your immediate family. You can go outside. You can be in your backyard as long as you are socially distanced from others, but it really means that you're taking yourself out of commission for a period of time. And the reason for that is you don't want to spread the virus. And if you're a contact who might be potentially getting the virus, you don't want to be spreading the virus even if you feel well, because again, as I mentioned, you can be asymptomatic for 48 hours. So you should also practice good hand hygiene, wear a mask, and socially distance as much as possible, even in home. And again, no one wants to intentionally spread this novel virus, but we may if we don't wear masks and follow the quarantine and isolation events. So I'll end up here by talking a little bit about what's happening, what we've been doing over the past couple of months with schools. We've been working very closely with Mike and his colleagues and the superintendent level, the school nurses, and the HR folks at schools. We produced over 75 frequently asked questions. We continue to update guidance and algorithms. We're aligning that with the primary care community as well. And we continue to have biweekly calls with Lancaster colleges and universities. And again, we're doing these webinars. Briefly about COVID in schools. I just want to end by saying that schools are doing a fantastic job at following the guidelines. In fact, we've seen very little in-school spread of the virus. talking to our partners at Department of Health, they related that as well. It seems that most cases that are occurring in schools are related to school activities outside the school, like parties, like small family gatherings or big family gatherings, or going to restaurants or other group activities, or car rides with others. And so what's happening now is that you see people being exposed, developing the virus outside the community that bring it into the school, but you're not seeing the reverse happen very often. So uh, schools are doing a great job. They are not, cases are not driving community spread. It's the other way around. The community spread is driving school cases. School nurses are aligned with family physicians and pediatricians and are following all the same algorithms. The PA Department of Health is aligned with our contact tracing program, which has reached more than 4,300 contacts to date, and continues to provide a significant source of decreasing pandemic spread in our community. And as before, I'll just close by saying that school closings will reflect the amount of cases in our community. So as our community practices social distancing, mitigation measures, and all the right things, that's going to protect in-school education. And I'll talk more about that on my second webinar on Thursday. But I will stop there and open it up for any questions. Oh, actually, you know what? One final word. So this is a nice quote from the WHO Regional Director for Europe. He said that the virus has been merciless whenever partisanship and disinformation prevailed. Where the pandemic goes from here is in our hands. We have fought it back, and we can fight it back again. And our own illustrious Brenda Boucher, who is our health promotion specialist and has, I know, worked with a lot of you folks in the schools. I like this quote that she said: "Prevention looks like overreacting when it works. Even those who are on board with public health measures are getting pressure to ease up, when it's actually those prevention behaviors that will allow us to keep life as normal as possible for businesses and schools." So I thought that was a rather articulate way to take a look at it. And I will stop there for questions.
Great, thank you, Dr. Martin. Couple questions in the chat box. And again, to all of our attendees, if you have any questions, please feel free to drop them into the chat box. The first question here, can you explain how false positives occur?
Yeah, so there's a couple ways how false positives occur. It has to do with the inherent accuracy of the test, and it has to do with the amount of COVID in the community. So when the incidence of COVID is low, then a test naturally loses its accuracy. And some tests are more inaccurate to begin with than others. So when you're dealing with a very low prevalence of COVID in the community, a test has more of an opportunity to have a result of a false positive than a true positive. And again, some tests are worse around having false positives than others.
Great, thank you for that. Another question here says, why if a sibling gets sent home from school with COVID symptoms, the sibling can still come to school if they're asymptomatic until a positive test occurs? And Laura, I'm gonna actually, since you posed that question, you can now talk, because I just wanna make sure we get clarification on that, what you actually asked there. And I'm trying to find her here. Laura, if you can unmute yourself.
So if a student gets sent home from school with COVID symptoms, their siblings still can come to school until a positive test gets taken.
Right, unless that child who was sent home from school had symptoms and was linked to someone with COVID-19 in the past 14 days. In that situation, all the household members would be considered contacts pending the test result, and they would have to stay at home until those test results come back. If it's just a child that has symptoms, now again, you only have about a 5 to maybe 8% chance of having COVID if you just have symptoms and you're not a contact with someone as well as having symptoms. And in that situation, because the risk is much lower, household members, siblings, parents, as long as they're asymptomatic, can return to work and school pending the test result for the child with symptoms.
Thank you.
And it basically has to do with risk. So we could quarantine everybody, but if we did that with everybody that's sent home from school with symptoms, there pretty soon wouldn't be anybody coming to school because we'd all be in quarantine. So it's a matter of trying to, find those higher risk cases, do the right thing when it's a probable case, and, still try to manage to keep people going to school and keep staff and everybody else being able to go do what work that needs to be done.
And from the school side with that particular situation, we don't just automatically jump to a probable case. So we actually work with the Department of Health. And if we can't get the Department of Health, we do call the team at LGH. And we will actually walk through, they want to be able, the Department of Health wants to be able to see that there's a true link to a positive case. And depending on the symptoms that a parent or guardian would share with us, that it actually would meet the symptom boxes, whether it's one symptom from box A or two or more symptoms from box B. For us to be able to classify something as a probable case.
Yeah, there's very strict definitions around it. So,
any other questions? Feel free to drop them in. All right, well, I don't see anything else coming in. Dr. Martin, thank you so much for your time today. Really appreciate all the information that you shared, specifically around what's happening here in Lancaster County. Not only some of the challenges, but also some of the good news, particularly when it comes to what's happening in schools all across the county. So again, thank you for your time. Thank you to all of our attendees who joined us today, and we hope you'll join us on Thursday for the next part of this webinar series. So have a great day, everybody.
Thank you all very much.